Hi, everyone. I'm thrilled to have Dr. Gupta here with us today. His presentation is Radiation 101. In this presentation, Dr. Gupta will give an overview of radiation therapy and then dive into the different types of radiation treatments utilized for gynecologic cancers. He will also discuss common side effects of radiation. Dr. Gupta is an associate professor in the Department of Radiation Oncology at Mount Sinai Health Systems. He specializes in the treatment of gynecologic malignancies as been a vital part of the gynecologic oncology team at Mount Sinai for 15 years. Dr. Gupta has become a well-respected thought leader in radiation oncology through his great accomplishments in the field. He has over 70 publications in major oncology journals and has presented his work at international conferences. Dr. Gupta is also dedicated to physician education and served as the associate residency program director in his department for a number of years. He earned the Association of Residents in Radiation Oncology Educator of the Year Award in 2011, 2012, and 2016. He combines his passion for teaching with his interest in global health by serving as a volunteer consultant internationally. Dr. Gupta, thank you so much for joining us today. We are very lucky to have you.
Great, thank you for that introduction. Can you guys see my screen, the PowerPoint slides?
Yeah.
Great, okay. As Jillian said, I'm a radiation oncologist here at Mount Sinai. I've been here for about 15 years. It's nice to see some familiar faces in the group. I have been working with the gynecologic cancer team here since I started in 2009. So chances are I know your gynecologic oncologist and a lot of the team members that you've been working with. I'm not sure if everyone here is a Sinai patient or has sought care elsewhere, but regardless, you're welcome. And uh, I'm going to be kind of giving an overview of just radiation therapy in general. And then I'm going to kind of briefly talk about the management of endometrial and cervix cancer in general. And then I'll be able to take some questions at the end. I'd prefer not to comment on specific situations that you may be going through. It's a little tricky in this forum because I don't have all the information, but happy to kind of try to answer some general questions. Okay. So let's just get started with some anatomy. I just want to make sure everyone understands the organs we're talking about. So this picture in the top left, you see the uterus is in the middle. At the bottom of the uterus is the cervix. And even though they're kind of all the uterus and cervix are connected and there's no real distinguishing characteristic between them, the cancers of the uterus and cancers of the cervix are managed separately. And so we just have to keep in mind that even though they're part of the same organ, they are treated separately because from when we're, in utero, when we're little tiny babies and embryos, they actually develop separately, but then they combine to form one organ. So even though they look like they're in one structure now, they did not originate that way. Below the cervix is the vagina. On the sides of the uterus are the fallopian tubes and the ovaries. I also wanted to comment on the uterus is kind of like a balloon-like structure. It's got a hollow middle, and the outsides are muscular walls. The cancers of the uterus typically start on this white line, which is the endometrium. The inner lining of the uterus is called the endometrium, and that's typically where cancers of the uterus start. It's important to know when we get to the uterus section and we talk about those endometrial cancers where they start. So I just wanted to point that out. This picture on the top right is just a side view of the same anatomy. Here is the uterus here. Again, at the bottom of the uterus is the cervix. Below that is the vagina. The uterus kind of flops over and kind of rests on the bladder that sits right there. And behind the uterus and the cervix and the vagina is the rectum. When we treat cancers of the uterus or the cervix or any kind of gynecologic cancer, you can see that some of the issues that we have are because the bladder and the rectum are so close, a lot of the side effects of treatment for the cancers of the uterus and cervix and the vagina really come from the proximity to the bladder and rectum. So people have issues with bladder and rectum after whether it's surgery, whether it's radiation, maybe not necessarily as much for chemo, but the surgery and radiation can certainly impact the bladder and rectum just because they're so close. I also have this picture down here, which shows the uterus and its relation to lymph nodes. Lymph nodes are usually a good thing. We have hundreds of them throughout our body. They help us fight infections. When you get sick, you may notice the lymph nodes in your neck get swollen. That's just them trying to fight infections. Unfortunately, lymph nodes can be a bad thing because sometimes cancers of the uterus or the cervix, they can involve the lymph nodes and cancers can spread through lymph nodes. So it's important to know that lymph nodes are pretty much all around the uterus. And oftentimes when we do surgery for cancers of the uterus or cervix, we may remove these lymph nodes to see if they're involved. And also when we do CAT scans or MRIs or PET scans, you sometimes note that lymph nodes may be enlarged um, because they may be involved with cancer. So that's important to know because that is how the cancers can sometimes spread. So a lot of women will have a hysterectomy, which means their uterus is removed for endometrial cancer. And so I just wanted to show what happens after the uterus is removed. So along with the uterus, the cervix is typically removed, and the surgeon creates something called a vaginal cuff, which means the vagina just ends in this blind loop. There's no more cervix or uterus. Often the fallopian tubes and ovaries are also removed. But you see here that this area is just stitched closed by the surgeon and over time heals and forms just a blind loop. And again, very close to the bladder and rectum. Okay, so this area again is called the vaginal cuff. So I just wanted to make sure you guys are familiar with that term because I will use it later on in the talk. Just wanted to briefly go over the history of cancer treatment because I think amongst all the kind of main categories of treatment, I think radiation is a little bit less known. So surgery has been used to treat cancer for over 5,000 years, believe it or not. There are records of Egyptians doing breast cancer surgeries, like mastectomies, over 5,000 years ago. I recently just saw something in the newspaper, like commenting on this, even doing brain surgery over 5,000 years ago. So the Egyptians were well ahead of you know what we would consider a treatment, for that time. It's really amazing that they were able to do surgeries for cancer that long ago. Obviously, they probably didn't have much in terms of anesthesia, so you can imagine those were pretty painful procedures. But so surgery is definitely the original cancer treatment. It was in 1895, so a little bit over, 100 years ago, where William Röntgen discovered X-rays. And this picture that you see here is the first X-ray ever taken. It's a picture of his wife's hand. That is not a diamond ring, but it is probably some kind of metallic ring that is showing up. And it's a picture of his wife's hand that he took when he discovered X-rays. And it was really, when he published that in a medical journal in 1895, word got around the world and people started really looking into X-ray both as a diagnostic tool to figure out like to look inside the body as well as using X-rays to treat cancers. So Henri Becquerel is a Frenchman, I believe, who discovered radioactivity in uranium. And then Marie Curie was a French scientist who discovered polonium. She named it polonium because she was actually from Poland and decided to name the first radioactive substance she discovered polonium and then radium. Unfortunately, in 1934, she died of anemia due to years of exposure to radiation because no one knew what the side effects were of radiation. So this is, people learn that this is not always a good thing, but it can be a bad thing. But remarkably, in 1896, so 1 year after the discovery of X-rays, Emile Grube, who was a medical student, in Chicago opened the first radiation treatment for cancer. These are his hands. Again, he was handling radioactive substances, and so his hands took a beating, and you see he had some amputations there, and he has a lot of warts and skin reactions from years of handling radiation with his hands. So we have learned not to handle radiation that way, and we are much safer in how we administer radiation these days. But I just wanted to highlight the fact that radiation treatment has been around for over 120 years. It is not new, it is not experimental, it has been around longer than even chemotherapy. Chemotherapy was not invented until the 1940s. So chemotherapy is only about 80 years old, so it's less than 100 years old. And the nitrogen mustards that we were first used for lymphoma, they were the first chemotherapy. These were developed at Yale. And so I just want to, sometimes when I meet patients, they think radiation may be this new experimental technique, but it's actually been around longer than chemotherapy. Not as long as surgery, but it's been around a long time. Okay. So I just kind of briefly mentioned to you the different kinds of cancer treatment options. We kind of create three different buckets of treatment. So for one bucket is surgery. The goal of surgery is to remove all or some of the tumor. It's typically used in patients that we're trying to cure. So we rarely do palliative surgeries. I'm not sure if you guys are familiar with the terms curative versus palliative. Curative is where we're trying to remove all of, get rid of the cancer completely from the body. Palliative is in those situations where we may know that it's not possible to remove all of the cancer, and we're really just trying to improve symptoms. So palliative is just improving symptoms, whereas curative is meaning we're trying to get rid of the cancer completely. So when we do surgery, it's typically curative. We rarely do palliative surgeries, anywhere in the body. Radiotherapy, it kills the tumor cells within an organ. So it doesn't get rid of the organ. So some people want to know that distinction between surgery and radiation. There are some situations where people have the option of having surgery or radiation. Surgery would remove not only the tumor, but usually removes the organ, whereas radiation just kills the cancer within the organ and the organ stays there. Radiation treatment can be used to cure people or to palliate people. So again, this is an important distinction between surgery and radiation. Surgery is usually to cure, and radiation can be to cure or to palliate. Usually your doctor should kind of tell you whether the goal of the treatment is to cure this or to palliate, similar with surgery. This is something that happens early on in the diagnosis. Chemotherapy, it kills tumor cells. It again does not remove the organ stays there. Chemotherapy is often used in conjunction with surgery and or radiation in the curative setting. So patients may get chemotherapy first, then surgery, then radiation, or kind of different combinations of these. But it's important to realize that chemotherapy by itself rarely cures cancer. So the exceptions are leukemia and lymphoma. In those situations, you can cure cancer with just chemotherapy alone. But in most other cancers of the body, chemotherapy is used with surgery or radiation. Once patients have metastatic disease, then chemotherapy becomes kind of the primary treatment, and radiation and surgery are typically just used for palliation. Um, within chemotherapy, I should probably change that title. It's probably better termed systemic therapy now, because within that umbrella we have, biologic therapy and immunotherapy. So those all kind of fall under the umbrella of like chemotherapy, systemic therapy. Okay. Any questions about these kind of different treatment options? No? Okay, great.
It looks like there's um,
Oop, I
I'm sorry,
have,
there's a question directed to me. I'm sorry, it was
okay.
about the recording.
Okay. Okay, so we'll move on. So there are, again, this is not specifically talking about gynecologic malignancies. Right now, I'm just talking about radiation treatment in general. There are two kind of different types of radiotherapy that we use. One is called teletherapy. Tele means distant in Greek, like telephone. You're contacting someone from a distance. So teletherapy is also known as external beam radiotherapy, and that's typically given by a machine called a linear accelerator. So this picture here on the top right is a picture of the first linear accelerator ever developed. It was developed at Stanford in California, and this patient, this 4-year-old boy, was the first uh, patient ever treated by a linear accelerator. He actually had cancers in his eyes. He had a retinoblastoma. His right eye actually was removed surgically, so he actually has a glass eye in the right eye. And then he developed the same cancer in the left eye. And so they did not want to take out the left eye also, because then he would be completely blind. So then they offered him radiation to the left eye. And this was done in like the 1950s. And this guy is still alive, believe it or not. And he has vision in the left eye. And luckily, it was a successful treatment, because otherwise I may not have a job. And so it worked really well. So this is a kind of a classic picture in radiation oncology with this 4-year-old boy getting treated with it. Here's a much more modern day picture of a linear accelerator. This may be similar to what you see in our department. Just so you know about other technologies, because people sometimes ask us about them when they come for consultations. So a cyberknife is a way to deliver high doses of radiation to a very small area, and that's what this machine is here. We don't typically use these in gynecologic cancer, so I don't really bring it up, but sometimes people see advertisements, on the subway or on TV about cyberknife, and they wonder if it's appropriate for them. To be honest, it's not really used in gynecologic cancer because we're usually treating a bigger area, and so it's not really appropriate. Often we use CyberKnife to treat brain tumors or small tumors in the lungs, things like that. Gamma knife is a treatment that we typically only use for brain tumors. Again, also heavily advertised, and so sometimes patients come in asking about gamma knife treatment, but it's kind of irrelevant here in the GYN cancers. Okay. Another type of radiotherapy is brachytherapy. Brachy means next to or approximately to in Greek, and that means we put the radiation right next to the cancer. Versus teletherapy, where the radiation is coming from outside the body. Brachytherapy, we usually put the radiation inside the body, and there's different ways to do that. We can put the radiation inside a cavity, and some of you may have had intracavitary brachytherapy with me. That's where we put the radiation inside the vagina and right up against the cervix or the uterus, and there's different ways. This is called a vaginal cylinder, where we put the radiation tube. I sometimes call this a tube. The cylinder we put in the vagina. This area here goes up against the vaginal cuff. If you remember, that's the um, part of the vagina that the surgeon creates after hysterectomy. So this rounded edge goes up against the vaginal cuff, and then the radiation moves through this tube up and down. It takes about 5 or 10 minutes, and then we remove the tube. This device here is called a tandem and ring, which is similar to a tandem and ovoid. These are typically used for cervix cancer. And so we put the instruments inside the vagina, and they can go into the cervix and uterus, and they can treat a cervix cancer internally. Interstitial radiation is where we use needles that pierce through tissue. This is an example of a Tenormin ring with needles, and this can, if someone has a larger tumor, we can use these needles to kind of go further outside. Instead of just treating from within the cervix, we can actually use needles to treat areas outside of the uterus and cervix if we need to. So the targets of radiotherapy and GYN cancers can be the cervix, the uterus, the vagina, and the perimetrium. I think I may have forgotten to mention what the perimetrium is. The perimetrium is this tissue next to the uterus and cervix, and so it's very important that we know if the cancer is involving this because it can change our treatment. So the perimetrium is that tissue next to the uterus and cervix. Okay. So everyone who gets radiation treatment goes through a process called a simulation. A simulation involves multiple things. One is a CAT scan. So here's a picture of a CAT scan. And we usually use some type of immobilization device. When we treat gynecologic cancers, we often use something to immobilize the hips. And sometimes when we're doing brachytherapy, we can use different kind of gauze, things like that to immobilize the brachytherapy applicator. So there's different immobilization devices we have. When we get the CAT scan, we delineate or essentially draw a tumor and the normal organs on the CAT scan slice by slice. So here's an example of a pelvic CAT scan that was taken at simulation. And you see here these kind of different colors for all the different organs. This potentially could be a cervix in orange, the bladder is in yellow, the rectum is in green, and these are the bones here in blue. And so the computer doesn't know where these organs are. I have to tell the computer where these organs are. So after your simulation, the reason we don't start the treatment the next day is it takes us some time to actually draw in all of these organs so that the computer knows what is what. I can tell you we're actually starting to use AI, artificial intelligence, can help and we've been able to train the computers to identify where the bladder is, where the rectum is. So the computer generates it, but then certainly a physician goes back, checks it over to make sure it's being done accurately. But it is one application of AI being used in our field. The entire treatment is based on this CAT scan that's done. So some of you may have had treatments, lasting weeks long, and it's all based on this CAT scan that we do prior to treatment. Once we identify where all the organs and the tumor targets are on the CAT scan, we perform some really sophisticated calculations to maximize the radiation dose to where the tumor is and to minimize dose to the normal organ so that there's fewer side effects. And so this is really where targeting of the radiation to the tumor is and trying to minimize dose to the other structures. And essentially, this is our operating room. This is where we design our radiation treatment similar to cutting out a tumor. Okay. And just so you get a general idea of the flow of the patient through a radiation department. So a diagnosis is typically made by a surgeon. For gynecologic cancers, it's usually by the gynecologic oncologist who diagnoses the cancer. And then they're going to order some staging studies that may include labs, CAT scans, PET scans, MRIs, whatever is appropriate. And then the patient's usually referred to us at that point. So we usually have all this information by the time patients come to us. And then we have to order a simulation and we have to get approval for the insurance company to make sure that everything's approved. That takes about a week. And then it can take anywhere from 1 to 10 days for radiation treatment planning. That's where we were doing kind of the drawing in of the organs and also those sophisticated calculations I was talking about. So that takes anywhere from 1 to 10 days. And then radiation treatment course can last 3 to 8 weeks. And then we typically follow patients for about 5 years after treatment. So most of my patients I see for about 5 years. So I may have used this silly joke that when I see you guys at consultation way back here, I tell you guys we're going to be friends for about 5 years. And that's because we get to this follow-up point of 5 years. And that's when I usually discharge you from the clinic. And usually you just see the gynecologist, regularly after that. Okay. Any questions about radiation treatment in general before I move on to management of endometrial cancer? Let me open up the chat here. It looks like there's one question in the chat.
I wrote a question, but it's more specific to gynecologic cancer.
Okay.
I just wanted to make sure I had it there just in case it slipped.
Do all gynecologic patients who receive external radiation also receive brachytherapy? So not necessarily. So I'm going to go through that in my kind of the management of each of these. Sometimes patients need either brachytherapy or external radiation, sometimes both. So it's and or. Okay. So we can talk about so before I get into the actual step-by-step management of endometrial cancer, just again, the radiation treatment options we have for endometrial cancer is external beam radiotherapy. It treats the vaginal cuff. Again, that's the space that's created by the surgeon after the uterus is removed. The perimetrium, which is the tissue next to the uterus, and then the pelvic lymph nodes that are remaining after the surgery. This is typically a daily treatment, Monday through Friday, for approximately 5 weeks. All right, so that's the external beam radiotherapy. And then the brachytherapy option is a cylinder. The cylinder only treats the vaginal cuff. It does not treat the perimetrium. It does not treat the pelvic lymph nodes. The vaginal cuff is the most common site of recurrence in stage 1 patients. This can involve 3 to 6 treatments over 3 weeks. And so just depending on the situation, what stage someone is, what type of surgery they had, and various other factors, patients may need either a brachytherapy cylinder or external beam. Sometimes they need both, just again, depending on the situation. Oops. So this is just showing where the dose goes when we give external beam radiotherapy. This is a little bit technical, but hopefully you can follow along. So when we give external beam radiotherapy, it's a pretty generous area that gets radiation treatment. So 100% means 100% of the dose is going to this rectangular area. So the vaginal cuff sits right here in the middle of that rectangle. The lymph nodes sit along the bones on the inside. So the white things are the bones, the pelvic bones. The lymph nodes sit just inside here, but the rectum is here and the bladder and the intestines are here. So they're actually getting full dose, even though we don't necessarily need them to. We do have some fancier techniques where we can minimize dose to the bowel, but essentially you see this entire pelvic content are receiving the full dose, even though we don't want to give the intestines dose necessarily because they lie so close to the lymph nodes. Sometimes they're kind of innocent bystanders, and this is why sometimes people can get diarrhea from the radiations because the intestines are irradiated. And 50% means half of the dose is spread out to the outside part of the pelvis. So you see even these bones and this is just fat out here is getting half of the dose, even though we don't want it to get any dose. The reality is it's pretty much doesn't really matter. There's really no side effect from this low dose. Sometimes people can get a worsening of their osteoporosis or osteopenia by having the bones irradiated here. But to be honest, it's usually irrelevant, but it's just showing how generous of an area external beam treats. When we deliver brachytherapy, on the other hand, you'll see the full dose of radiation. This red circular area is much smaller than this area getting external beam radiation. You'll see the bladder is largely doesn't get any. The rectum is back here. It barely gets any of the radiation dose. And here's this blue line is the half of the dose. And you'll see it's a much smaller area than this green line here. So again, depending on the situation, brachytherapy may be sufficient because it just treats a very small area. Here at the top would be the vaginal cuff. We put the cylinder in right up against the vaginal cuff. So this is the vaginal cuff. Um, and this is a frontal view of the body, and you can see it's a much more generous area that's getting the dose. And again, sometimes it may be necessary to treat that, and sometimes it's not. Because brachytherapy treats a smaller area, it has fewer side effects. And so we prefer to use it if we can, but the situation may not be appropriate. We may need to use something else. Okay. So briefly, endometrial cancer staging. I don't want you guys to try to memorize this or take notes on this. This is just largely just to talk about the cancers in general. So stage one means the cancer is limited to the uterus only. It hasn't gone anywhere else. And so we mentioned that cancers of the uterus start on the endometrium, the inner part of the uterus, and they can grow outward. So here's an earlier stage cancer. It's limited to less than 50% of the uterine wall, whereas 1B means it's going across that 50% threshold. Stage two is when it goes down and involves the cervix. Stage three is when the cancer goes outside of the uterus but stays within the pelvis. So these are some technical terms that you may not necessarily need to know all of, but if it involves the ovaries or fallopian tubes, the perimetrium we talked about is the tissue next to the uterus. If it goes to the vagina or the lymph nodes, these are all different ways of being stage three. Stage four is when the tumor involves the bladder or rectum, or when it has spread through the blood to the lungs or the bones or something like that. When we treat endometrial cancer, almost always the first step is surgery, which is usually a total hysterectomy. Again, that means the uterus and the cervix are removed, usually along with the fallopian tubes, the ovaries, and lymph nodes. Post-operative treatment depends on risk factors. So not everyone who has endometrial cancer and who gets surgery needs further treatment. Some patients do. And the things that help us determine this are the stage, which is the most important. We talked about myometrial invasion, which is how much the tumor goes through the uterus wall. Lymphovascular invasion. So in order for the tumor to go from the uterus to the lymph nodes that sit next to it, there are highways that go from the uterus to the lymph nodes. And so if it involves those highways, it's called the lymphovascular invasion, we get nervous. Histology, so there are different types of cancers of the uterus. There's adenocarcinoma, there's papillary serous carcinoma, there's clear cell carcinoma. So depending on the type of cancer, you may have a different treatment. And then the grade of tumor, which is different than stage. Grade means how quickly is it growing under the microscope. And typically we assign a grade of 1, 2, or 3. Grade 1 typically means it's growing slowly. Grade 3 means it's a little bit more aggressive. And then grade 2 is in between. We look at the age of the patient. As patients age, endometrial cancers can sometimes be more aggressive. So we actually tend to treat older patients more aggressively than we do younger patients. This is actually the exact opposite of breast cancer. In breast cancer, the younger you are, the worse off the disease is. But in endometrial cancer, the older you are, the worse it is. And so based on all of these risk factors, we put people into different risk groups. Um, Low risk has these features. It is the most common risk group, which is great. So that means most women have a very low risk of recurrence for endometrial cancer, and surgery alone is typically all that's needed, and we don't recommend any treatment after surgery. Intermediate risk group. So these patients have about a 10 to 25% risk of recurrence after surgery alone. The features that go into risk group, it's pretty complicated. I don't want to go through the details of it because it can be very confusing. It's outside the scope of this talk. Radiation may be recommended to reduce the risk of the cancer coming back. I had mentioned that vaginal cuff is the most likely site for recurrence in early stage patients. Radiation after surgery improves the risk of recurrence from 10 to 25% down to 3 to 15%. Radiation has not been shown to improve survival, but it does improve the risk of recurrence. So this is when we really get into a risk reward discussion with our patients because the radiation reduces the risk they'll come back, but it doesn't necessarily improve survival. Because brachytherapy with that cylinder has very little side effects, we say that that may have the uh, biggest bang for its buck. High-risk patients are patients who have more advanced disease or more aggressive histologies. These patients have more than a 50% risk of recurrence after surgery alone. Recurrence may be distant, meaning it may spread through the blood into the lungs and bones, or it may recur in the pelvis. Patients who have high-risk disease, they are often given chemotherapy with or without radiation. Chemotherapy has been shown to improve survival, whereas radiation just reduces the risk of the cancer coming back. And then the radiation sequencing can be given during the chemo or after the chemo. Okay, so to summarize for endometrial cancer, surgery is the main treatment. Some patients may need treatment after surgery, and it depends on several risk factors. And so in early stage patients, we look at the age, the grade, how much myometrial invasion there was, and if there was invasion into those highways to the lymph nodes, the lymphovascular invasion. Patients who are low risk have no further treatment after surgery. Patients who are intermediate risk may be offered radiation because the radiation can improve recurrence rates, but it has not been shown to improve survival. As we mentioned, brachytherapy kind of has the biggest bang for its buck, so we often use these for those intermediate risk patients. High risk patients typically get chemotherapy with or without radiation, and if we do the radiation, the timing can be variable depending on the situation. Okay. Um, Let me go to the chat to maybe answer some questions. Um, so someone commented on the side effects about pelvic fractures from radiation. So I can address that towards the end because I am going to talk about side effects towards the end. Does the impact of radiation change based on one's age and or other health? So I'm not sure if I understand this question correctly. Does the impact, meaning does the side effects change based on one's age and or other health issues? So, if someone has a history of, let's say, Crohn's disease or other kind of, I'm not sure if you all know what Crohn's disease is, but it's a sensitivity or it's a type of inflammatory bowel disease where patients have a lot of diarrhea. So those are patients that we may try to avoid external beam radiation on because the external beam can certainly increase the diarrhea. So if someone has other, that's one of the health issues that we really take into account. Some people who have lupus or other autoimmune diseases, they can also potentially have a more exaggerated reaction to the radiation. So we certainly do look at that. Age by itself, we don't really consider, necessarily, a risk factor. It's really just the other medical problems a patient has. I have treated 85-year-old, 88-year-old women who are in great shape. I have treated them very aggressively and they've tolerated. I still see them, years out and they're great. But, I've also seen some, 45-year-old women who have multiple medical problems who wouldn't have been able to tolerate such aggressive treatment. So it's really more about the other medical problems than age. We don't, we try to take everything into account. Okay.
It looks like someone wrote like kind of a follow-up question.
Oh.
She wrote, if I understood what you said the older the person, the more aggressive the treatment.
Exactly. So this is for endometrial cancer again. So patients who are maybe borderline needing treatment at age 50, if they have the same features of their cancer and they're older at age, if someone's age 70, we may be more inclined to treat the 70-year-old than the 50-year-old, believe it or not, because their cancers tend to be more aggressive. So that's how we incorporate age if someone's kind of on the borderline. There are multiple studies showing that endometrial cancer is more aggressive in older patients, so we tend to have a lower threshold to treat those patients.
Thank you.
What is being done to minimize the side effects of bladder and bowel? Uh, so we have fancier techniques to target radiation. So I had mentioned, I'm going to go back a couple. So this rectangular area, we can now target this to be more like a horseshoe shaped radiation dose so that we're minimizing dose to the bladder and the bowel, because most of what we need to treat is actually kind of like a horseshoe because the pelvic lymph nodes sit along here, and there's a technique called IMRT, which is a fancy way of delivering radiation treatment that allows us to target the radiation better. And so that's a big thing that we're doing with radiation now to try to minimize it. And then again, as I mentioned, brachytherapy, which is not new. It's been around for 100 years. Brachytherapy, as I mentioned, was one of the first treatments, radiation treatments that was given years and years ago. So this is also a very targeted way of delivering radiation where it gives very little dose to the bladder and rectum and the intestine. So if we can use this in this appropriate situation, we do use that. Okay. Great, good questions. Okay, let's go to the next section, which is on cervix cancer. The radiation techniques available for cervix cancer are, again, external beam radiotherapy, which is almost identical to what we do for endometrial cancer. But often when we treat patients with cervix cancer, they still have a cervix and uterus. A lot of our patients don't have surgery first. I mentioned that cervix cancers and uterus cancers are managed differently. And so oftentimes surgery is not an option for patients with cervix cancer. And so the patients may have an intact cervix and uterus when we treat them with external beam radiation. And again, the perimetrium and the pelvic lymph nodes are targets as well. This is daily treatment, Monday through Friday for about 5 weeks. Again, similar to the endometrial description. Brachytherapy, there's a different type of brachytherapy we use for cervix cancer. We use devices called either tandem and ring or tandem and ovoids. They're very similar. Some institutions have rings, some institutions have ovoids. I've used both. They both have their pluses and minuses, but it's similar treatments. The targets are just the cervix and uterus. So you see the external beam treats a much more generous area. This is typically weekly treatment over 3 to 5 weeks. There's some variability in the scheduling, but it's much fewer treatments with brachytherapy. I showed this picture earlier. We have devices that go into the vagina and potentially in through the cervix into the uterus, and then the ring would sit just at the bottom of the cervix, and we can deliver radiation through these tubes. These are typically done under anesthesia, whereas the cylinder, it's not as painful. That doesn't require anesthesia, but these are bulkier applicators, so we typically do these in the operating room under anesthesia. If someone's not a good candidate for the operating room because they have, lung problems or heart problems, I have done these in my clinic with just oral pain medication without them being under general sedation, and it works, but I think it's much more comfortable to be able to do this in the operating room. Okay. There are various kinds of brachytherapy applicators. I hope I'm not scaring you guys with these pictures. They look pretty archaic, but they have been modified over the years. And so there are different types of applicators for different situations. This is the radiation machine where when we use the brachytherapy treatments, there's an actual pellet of radiation that's stored in this area here. And when we insert these applicators into the patient, we then attach the applicator or the tubes through a wire, and that's how the radiation is delivered for brachytherapy. Okay. Cervix cancer staging is really complicated. Just kind of broad strokes, stage 1A cancer is microscopic. That means it can't be seen with the naked eye. It's just picked up on pap smear when they look at it under a microscope. Stage 1B is when you can actually see it with your naked eye when we do our pelvic exams. Stage 2 is when it's kind of gone outside the cervix and involving either the vagina or the perimetrium. Stage 3 is when it's involving the lower vagina or the involving uh, causing the ureters to be blocked off, which the ureters are right next to cervix. And when the ureters are blocked off, it can cause a malfunction of the kidney, such as stage 3B. Stage 3C is when it involves lymph nodes. And then stage 4 is when it involves the bladder, rectum, or it spreads through the blood to other organs like the lungs or the bones. Okay. So treatment by stage, when someone has an early stage cervix cancer, we typically offer them surgery. Sometimes they may need radiation after surgery, depending on the surgical findings, but we hope that surgery alone is all that they need. Once someone has a tumor that's more than 4 centimeters big, which means it's stage 1B3, or if there is lymph node involvement, then they require external beam and brachytherapy. We usually do not do surgery if the tumor is bigger than 4 centimeters or if it involves lymph nodes. We typically treat them with external beam and brachytherapy along with chemotherapy. We try to complete this treatment within 7 to 8 weeks. They have found, again, multiple studies have shown if you go beyond 8 weeks of treatment, the chance of the treatment the cancer coming back increases by 1% per day, which is crazy. So if your treatment is prolonged, a week or 2 weeks, that means the cure rate goes down by 7 to 10% 1 week. And so there's a huge time crunch to try and get things done within 8 weeks. It's a very complicated treatment schedule, but the clock starts ticking on the first day of treatment. Okay. The reason we don't do surgery for more advanced stages is that they have found that if a tumor is, say, 5 centimeters or it involves the lymph nodes, if they do surgery first, they do surgery by itself, they know that their cancer has a high risk of coming back. So then we know to prevent that cancer from coming back, we have to give radiation after the surgery. And by doing surgery and radiation, it actually has more side effects than just doing the radiation alone. So we typically don't recommend doing surgery first if you have a more advanced cancer. Okay. So conclusions from cervix cancer is that surgery is preferred for early stage cancers. Postoperative radiation may be given depending on the findings from surgery. We use chemo and radiation if you have a more advanced stage of cervix cancer, and then the radiation requires both external and brachytherapy in the situation. Okay. Let me answer some questions from the chat before we talk about side effects. Um, how frequent is pelvic discontinuity post-treatment? Yeah, so unfortunately, the weakness of the bones from radiation, it can be a permanent thing. And so patients may develop, it also depends on what your baseline is. If someone is already has osteoporosis at the time they're diagnosed with their cancer, and then they have to go through this, they're at higher risk from complications. If someone is, has had a history of smoking and other medical problems, their bones may be weaker, and then they're more susceptible from damage to the bones from radiation. And unfortunately, it's potentially a long-term side effect. Another patient 10 years out with ongoing bladder, nerve, and stomach side effects. Yes, there can be some permanent side effects from radiation. It's not common that they have it, but it is certainly possible. Okay. So I told Jillian before I started this talk that most of the times when I do these talks, most of the questions are about side effects. And so I have some slides, a slide or two dedicated on the side effects. There are different side effects from external beam and from brachytherapy, and we divide them into acute and chronic. Acute side effects are side effects that occur either during treatment or shortly after. Chronic side effects are side effects that can develop months to years after radiation is delivered. For external beam, acutely, patients often have diarrhea, potentially even rectal bleeding. A lot of the rectal bleeding is not necessarily from inside the colon. It can actually be due to hemorrhoids being irritated. And because they have diarrhea, frequent bowel movements, frequent wiping, that can cause some blood on the toilet paper. But certainly some patients do actually have blood in the stool or in the toilet water during or after treatment. Because the bladder is so close to the organs that we're treating, patients get irritation of the bladder, which causes the bladder to fire more frequently. So they have frequent urination. They can also say they have some trouble holding their urine. So when they go, they got to immediately run to the bathroom. It's harder to hold it. Patients can have dysuria, which means burning with urination. It almost feels like a urinary tract infection. Sometimes it's hard to differentiate, and so we'll get a urinalysis and check for a UTI because sometimes, like I said, it's hard to distinguish, but it's a very similar sensation. Hematuria is blood in the urine. That's much more rare, but certainly can happen from radiation. Patients often get fatigued from radiation, and they can have skin desquamation, which is peeling, maybe even darkening of the skin, especially in the skin folds in the groin area. Um, Chronically, patients can have diarrhea and rectal bleeding, so they may not have diarrhea during treatment. It can develop after treatment, or maybe it's persistent and it doesn't go away. People can have blood in their stool that can develop a year, 2 years after treatment. They need a colonoscopy or a procedure to stop the bleeding. They can have the same issues with the bladder. Uh, Urine and stool leakage is pretty uncommon, but certainly possible. I don't see that very often. Bowel obstruction or perforation, that's where the bowel obstruction means that the intestines get scarred from the radiation and gas and stool cannot pass. That can sometimes be an emergency where patients need to be hospitalized. Very rare that it happens, but sometimes it can happen from surgery alone. I just recently had a patient who had surgery. She came to me for radiation after, and then even before we started radiation, we found that she had an obstruction in her bowel. And so, having two treatments, surgery and radiation, can certainly increase that risk. I had mentioned patients who have more advanced cervix cancers, we don't like to do surgery first because if you do surgery, then radiation, you're at increased risk for complications. And one of those things is obstruction. Perforation is a hole in the bowel. Sometimes radiation can burn a hole through the intestines. Extremely rare, but again, possible. Leg edema is, swelling that can happen in the legs from radiation. Again, that's used to be more common when they did more extensive lymph node surgeries in the past. Now they have not done as extensive of lymph node surgeries, and so we don't see leg edema as commonly, but it is possible. Um, Femur and pelvic bone fractures, I think we kind of talked about them. These are unfortunate complications. I think they are underreported in the literature. I have been, I've seen this in my patients. And so if someone asks what is being done to minimize this, so we use these fancier techniques called IMRT to try to minimize the dose to the organs nearby. There's also a range of dose that people can use that is considered to be effective at controlling tumors. I tend to treat on the lower end of this range to try to minimize side effects. But some physicians go to the higher end because they're more concerned about preventing recurrence. And this is just it's just a matter of a few treatments. That's it. It's not a huge difference in the dose, but I tended to go on the lower side to try to minimize these pelvic fractures because I know that can be debilitating. It causes pain potentially forever. There's not great treatment for it. People can try physical therapy. They can try, some over the counter or some kind of prescription medications, but unfortunately, there's not a whole lot that can be done. So I'm sensitive to this. So I tend to use a lower dose of radiation to try to minimize these fractures, but it's still seen, unfortunately. Um, Brachytherapy acutely, this depends on if someone's getting a cylinder or the tandem and ovoid brachytherapy. There are different side effects for them, but patients can get diarrhea, they can get pain on urination, they can get uterine perforation. So that means the uterus gets a hole in it. The tandem that we insert, it should be inside the uterus, but occasionally this tandem can poke through the uterus. Uh, and it's usually not a major complication. The uterus is a very strong muscle and heals on its own, but it can happen. Um, What's more worrisome is if we perforate through the uterus and then we hit bowel. Fortunately, I've never caused that, but it is possible that the tandem can go through the uterus and bowel. Vaginal laceration, that's a tearing of the vagina while we do these procedures. Extremely rare, but it can happen. Chronically, patients can get vaginal dryness, fibrosis, and shortening from brachytherapy. We often give patients what's called a dilator to try to prevent these side effects and try to prevent shrinkage of the vagina. We also have available pelvic floor physical therapy that we may send patients to try to minimize this. And so we try to do this mostly to improve sexual function. Urethral stricture, that's when there's scarring inside the urethra, which makes it difficult to pass urine. Possible, but very rare. Fistula is extremely rare. That's when there's an abnormal opening between the vagina and the bladder, or the vagina and the rectum, which may cause leakage of urine or leakage of stool. Extremely rare that happens, but it is possible.
Thank you so much for this wonderful talk. I learned a lot, and it sounds like everyone else did as well. So everyone, have a wonderful rest of your day, and see you next time.
Great. Thanks for everyone.
Thank you.
Thank you,
Thank you.
everybody.
Take care. Bye.